Yes, sir. Three, two, one, start.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a class on chronic kidney disease, and this will be presented by our resident, Dr. Amit Kashyap, and would be moderated by our faculty, Dr. Ajayraj. So I would request Dr. Amit to kindly share his presentation. You.
Good morning, everyone. I am presenting a seminar on the topic of chronic kidney disease. My moderator is Dr. Ajayraj Singh Hada, sir. CKD is defined as kidney impairment sustained beyond 3 months with a reduction in GFR, structural abnormality in the kidneys and/or albuminuria. GFR of 60 ml per minute per 1.73 meter square and is excreting 3 gram per day of albuminuria is more likely to progress to end-stage renal disease. Here is the grading system of the CKD according to the GFR. Grade 1 GFR is more than or equal to 90, grade 2 60 to 89, grade 3A 45 to 59, grade 3B 30 to 44, grade 4 15 to 29, and grade 5 less than 15. Here we can see the formulas which can calculate the GFR. Now, incidence of CKD in India. According to nephrology dialysis transplantation, there are 7.85 million chronic renal failure in India, and most common cause is diabetes. Next is hypertension, and unknown causes are 15%. CKD is more common in women than men. Prevalence of CKD in India is 10 to 15%, and 2 lakh to 3 lakh cases are added annually. 10,000 to 12,000 renal transplant are done annually. 80% are living donor transplant. Most recipients are between age of 30 to 60 years. In the United States, the incidence is 373 new cases per million. End-stage renal disease in the United States is total is 7 lakh, around 7 lakh. The number of kidney transplant are more than 20,000 annually, and 1/3 of the transplant coming from living kidney donors. 87% of patients with end-stage renal disease started hemodialysis, 10% on peritoneal dialysis, 3% received preemptive kidney transplant, and survival in transplant patient was 69 to 85%. The mortality rate on dialysis was 164 per 1,000 patients here, and in transplant recipient was 29 per 1,000 patient years. Here are the risk factors, and the most common I have discussed diabetes, and there are many other risk factors. Here are the chromosomal abnormality which can lead to the chronic kidney disease. Pathophysiology. There are vasoactive molecules, cytokines, growth factor, and renin-angiotensin axis, which causes glomerular hypoperfusion, hypertension, hyperfiltration, leading to glomerular hypertrophy, then sclerosis, which reduces the renal mass. Here we can see the pathologic picture of the chronic renal failure showing the sclerosis. CKD itself is causes generalized manifestation, including polyuria, oliguria, hypertension, heart failure, anorexia, nausea, vomiting, pruritus, failure, restless leg syndrome, muscle twitching, dialysis, encephalopathy, decreased inflammatory response, pneumonitis, fracture, fruit drop, renal osteodystrophy. In the reproductive system can cause amenorrhea, infertility, decreased libido, hyperkalemia, metabolic acidosis, hyponatremia. Serum urea and creatine levels are commonly used to assess kidney function, but there are many toxins accumulate as the glomerular filtration rate decreases. So, relying solely on urea creatinine should not be done. Sodium water hemostasis. CKD patient maintain normal plasma sodium levels, extracellular fluid volume expansion, often presenting as peripheral edema or resistant hypertension. Thiazide diabetics are less effective in advanced diseases of stage 3 to 5. Loop diabetics with metolazone may enhance effectiveness. Urinary potassium excretion does not decrease due to aldosterone. Hyperkalemia can also increase dietary potassium. hemolysis, metabolic acidosis, RAS inhibitors, spironolactone, and other potassium-sparing diuretics. Patiromer may minimize hyperkalemia risk. Metabolic acidosis. Most patients able to acidify their urine despite reduced ammonia production. Hyperkalemia lead to uh, both hyperkalemia and hyperchloremic metabolic acidosis. As GFR declines, urinary acid excretion may drop to less than 30 to 40 millimole per day, causing metabolic acidosis. Metabolic acidosis is mild with pH rarely falling below 7.32. Uh, Bone manifestation of CKD. Elevated PTH can cause osteomalacia due to insufficient active vitamin D. Elevated phosphate level stimulate the production of fibroblast growth factor 23 by osteocytes, which lead to cardiovascular risk and mortality. Treatment of calcium and phosphate disorder. Once the parathyroid gland becomes significantly enlarged, controlling the disease becomes challenging. They should adhere to a low phosphate diet and use phosphate binding agents. Sevelamer and lanthanum do not contain calcium and are effective without increasing the risk of hypercalcemia. Cinacalcet and calcitide, which enhance parathyroid responsiveness to calcium. Tenapanor can decrease gastrointestinal phosphate absorption, which also decreases the parathyroid hormone. Hypertension in CKD should maintain under the 130 by 80 millimeter of mercury. AC inhibitors and angiotensin receptor blockers are preferred as they may preserve kidney function. Polycystic kidney disease patient with cyst more than 10 centimeter may decrease renal function on ACE inhibitors. Sodium glucose co-transporter 2 inhibitor like glyphosate can reduce cardiovascular event in diabetes patient. Treatment of other organ system. CKD can also lead to pericarditis, which need urgent dialysis, and it can treated by pericardial drainage. Erythropoiesis stimulating agent are also used in anemia. To start with the erythropoiesis stimulating agent, patient requires sufficient iron stores and adequate level of vitamin B12 and folate are essential. Peripheral neuropathy generally become apparent in stage 4 of CKD. Peripheral neuropathy in the absence of other causes need renal replacement therapy. Many complications improve with dialysis. Glucose metabolism is often impaired in patients with chronic kidney disease. Insulin plasma level tend to change. Metformin and sulfonylurea are contraindicated. CKD patient need thorough medical history. Family history may reveal genetic form of CKD or exposure to nephrotoxic agents. CKD include a history of hypertension, diabetes mellitus, abnormal urinalysis, and pregnancy-related issues such as preeclampsia. Investigation of CKD focus mainly on underlying diseases. Calcium level, serum, and urine protein electrophoresis should be conducted for multiple myeloma. Test for autoimmune diseases like lupus and infections such as hepatitis B, C, and HIV should be done. Phosphorus, vitamin D, parathyroid hormone, hemoglobin, iron, vitamin B12, and folate level should also be assessed. A 24-hour urine protein excretion more than 300 milligram lead to end-stage renal disease. Renal ultrasound evaluate kidney symmetry and size and the rule and rule out masses or obstruction. Polycystic kidney disease typically present with enlarged kidney features, multiple cysts. Radiographic contrast imaging is generally not beneficial in chronic kidney disease. Sodium bicarbonate and N-acetylcysteine preserve the renal function. In early stages of CKD without a clear diagnosis, a biopsy might be essential. Genetic testing can help identifying underlying genetic causes of CKD. Patient also need dialysis in case of extracellular volume expansion, hepatic coma, hyperkalemia, hypercalcemia, hypertension, and uremia. There can be conventional hemodialysis and peritoneal dialysis. In conventional hemodialysis, it is usually done 3 times per week, 3 to 4 hours per session, and the rate is 200 to 400 ml per minute. Daily hemodialysis is also used. Patient usually do their dialysis at home, and nocturnal hemodialysis is similar to conventional hemodialysis, which is performed while the patient is asleep, and the session is 6 to 10 hours. Hemodialysis can be done with anticoagulation or without anticoagulation. With anticoagulation, usually heparin is started at 50 to 100 unit per kg of heparin at the initiation, then followed by 100 unit per hour at a bolus. And low molecular weight heparin can also be used, which also help in improving the lipid profile and have less osteoporosis, less pruritus, and need less blood transfusion. Here we can see the tumoral calcinosis, patient who have a increased phosphate and the calcium deposits. I've already described the hemodialysis without anticoagulation. Usually, only the dialyzer is flushed every 15 to 60 minutes with 50 ml of saline. Peritoneal dialysis, as the name suggests, peritoneum is used as the membrane through which fluid and dissolved substance are exchanged with the blood. It is used to remove excess fluid, correct electrolyte, and remove toxins. Peritoneal dialysis has better outcome than hemodialysis during the initial years. Now, finally, patient have to do the renal transplantation, and the indication are end-stage renal disease, glomerulonephritis, pyelonephritis, congenital abnormalities, nephrotic syndrome, polycystic kidney disease. The donor kidney can be from brain dead donor, donation after cardiac death, or living donation. There can be donation after cardiac death can be controlled or uncontrolled. Here we see the intro picture of the where we flush the solution of at a temperature of approximately 4 degrees centigrade. This flushes out the microcirculation to prevent thrombosis. It cools the organ to a temperature of less than 5 degree and so reduces the oxygen requirement. It also replaces the normal extracellular fluid with the preservation fluid. This is the life port system. It is a hypothermic perfusion machine. It continuously recirculates the vasculature at low temperature and at the pressure of 30 mm of mercury. The perfusion fluid is based on University of Wisconsin solution, and some system include oxygenation. This technique flushes the microcirculation more effectively. There are trial and meta-analysis data showing the hypothermic machine perfusion reduces the rate of delayed graft function in renal transplantation. Uh, Here is the normothermic machine perfusion system for donation after circulatory arrest. It can recirculate the donor's own blood for 2 hours, and the underlying principle is to avoid early cold ischemia injury. It shows the reduced rate of early allograft dysfunction. Here we can see the intraoperative picture of anastomosis of renal artery with internal iliac artery, renal vein with the external iliac. Post-transplantation, living donor kidney normally require 3 to 5 days to reach the normal functioning level, while cadaveric donation needs 7 to 15 days. If complication arises, additional medications such as diuretic may be administered in order to help the kidney produce urine. Immunosuppressants are also added. Here we can see the different immunosuppressants acting on the different cellular level. Post-operatively, kidney are periodically imaged by ultrasound in order to assess the physiologic changes that often accompany transplant rejection. Imaging also allows the evaluation of supporting structure such as anastomose, transplant artery, vein, and ureter. There can be the rejection. Acute cell-mediated rejection is around 10 to 20%, and the incidence is mostly in the first 3 months. Initial treatment is done by high-dose intravenous steroids, which are successful in 90% of cases. And if it is steroid resistant, then patient can be given intravenous antithymocyte globulin. Acute antibody-mediated rejection usually occur less than 5% patient. It is caused by the human leukocyte antigen, donor-specific antigen, which are produced from a previous transplant, blood transfusion, or pregnancy. Treatment is by plasma exchange to remove circulating antibodies. Rituximab can be used. It is an anti-CD20 monoclonal antibody, which also reduces the production of donor-specific antigen. There are other transplantation like dual kidney transplant. These kidney transplant can be placed in the same iliac fossa. This approach is used for kidneys from elderly, donation after cardiac arrest, donors, and also called expanded criteria. And these criteria included the age more than 60 years or age more than 50 years with at least of the two of the following: hypertension, terminal creatinine more than 133 micromole per liter, death from stroke. There can be the early graft dysfunction, which can be indicated, suggest can be indicated by the more than 10% of creatine rise from the baseline or more than or equal to 20 micromole per liter. And the possible causes are acute rejection, calcineurin inhibitor toxicity, dehydration, urinary tract infection, pyelonephritis, renal vein or artery thrombosis, ureteric obstruction or urinary leak. Delayed graft dysfunction causes are uh, acute cell-mediated or acute antibody-mediated rejection, early ischemia, reperfusion injury, chronic calcineurin nephrotoxicity, ureteric or bladder outflow obstruction, recurrent urinary tract infection or pyelonephritis, BK polyomavirus nephropathy, glomerulonephritis, renal artery stenosis, poorly controlled hypertension, dyslipidemia. Here we can see the patient and graft survival after renal transplant. 10-year patient survival in live donor is 90% and disease donor is 80%. 10-year graft survival in live donor is 80% and disease donor is 75%. Thank you.
Thank you. So I welcome once again to all our faculty residents and those who might have joined us today. So if you have any query, if you have any suggestion, or if you want to make any comment, please let me know so that we can just discuss it. So we'll briefly summarize the whole thing. The main topic was chronic kidney disease. So we are discussing more of chronic kidney disease and not ESRD or renal transplantation here. So anyway, so chronic kidney disease, we all know, is a very prevalent condition. By an estimate, it is seen that around 700 million people throughout the world suffer from chronic kidney disease. It's almost 9% of the whole population. And almost 6 to 7 million people die every year of chronic renal failure. The Indian statistics, he has already said. So there are a lot of patients who do not receive dialysis. So almost 70–80% did not able to receive dialysis, and transplant is done only in 1 to 2% of the whole set of patients of end-stage renal disease. By definition, chronic kidney disease is injury or decrease in the kidney function, which may be due to any cause and which extends for at least 3 months. And it is estimated by either the eGFR, which goes below 60 ml per minute, or by proteinuria, which is more than 30 milligram, or albuminuria. It can be, we can also estimate the albumin creatinine ratio. Once a patient is diagnosed of chronic kidney disease, it is very important to know that we need to have a baseline level before we diagnose a case of chronic kidney disease. So it has to be there for at least 3 months. So if you do not have that baseline value with the patient, then the other way is to by imaging technique. If the imaging technique shows decreased kidney size or irregular kidneys or multiple cysts on both sides, so that gives you an idea that this could be a chronic kidney disease. Otherwise, we need to repeat the serum creatinine or eGFR to label it as a case of chronic kidney disease and not acute kidney injury. The grading is very important, as he has already discussed. According to eGFR, there are 5 grades, the G1, G2, G3, and G3 is divided into, again, 3A, 3B, and 4 and 5. So 4 and 5 are quite a severe kind of CKD, which usually will land up in end-stage renal disease and would require renal replacement therapy. And then the other grading is that according to albuminuria, so A1, A2, A3, less than 30 milligram, 30 to 300 milligram, and more than 300 milligram. And depending upon these 2 gradings, we do a risk stratification of these patients. And risk stratification, as we discussed on the heat map, right? So that map, which shows green, yellow, orange, and red color, is called the heat map, where you tell about the degree of risk to the patient of chronic kidney disease. So the green color means the patient is either normal or it's a minimal risk. So patients with more than who are either G1 or G2 and where it is A1 or less than 30 milligram. And then slowly, as you have increase in the grading of decrease in eGFR or increase in proteinuria, there will be increase in risk. So it is considered that the moderate risk, because around 72% patients fall under moderate risk, 17% will fall under a severe risk, and about 5 to 7% will fall under very high risk, which is almost the end stage renal disease. So when a patient comes of chronic kidney disease, we must also know the cause of the disease. So there are various causes, as he has mentioned. So while evaluating these patients, besides doing the eGFR and the urine routine examinations on the 24-hour urinary protein or albumin creatinine ratio, and imaging of the patient and taking a proper history and physical examination, then we need to know exactly how to manage these patients, right? So management of the patients will depend upon, first is the treatment of the underlying cause. So if the patient is suffering from hypertension or hypovolemia or sepsis, right? Or if it is due to drug induced, so all this should be taken care of. Once the cause has been taken care of, then we need to manage these patients to delay the progression of the disease. So how do you delay the progression? You educate the patient, you tell them about the dietary and fluid management. You tell how to control the blood pressure, which is very important, and how to reduce the proteinuria. So proteinuria, there are various drugs which can reduce proteinuria, particularly the ARB and the ACE inhibitors. And then we need to also know that particularly almost 30% of these patients are because of the diabetic nephropathy. So there is another drug which is called SGLT2 co-transporter inhibitor, sodium glucose co-transporter inhibitor. These are glyphosines, right? So there are various glyphosines available in the market, which will help you to delay the progression of the disease, particularly in patients with diabetic nephropathy with proteinuria. And then you have to manage the complications. Complications, one of the major complications, the patient may land up in end-stage renal disease, can have cardiovascular complication, can have sepsis, infection, malignancy. So all these complications need to be taken care of, plus the dyselectrolytemia, the fluid electrolyte imbalance, the fluid overload, hyperkalemia, hypocalcemia, hyperphosphatemia. So all these need to be taken care of while managing these patients. Particularly as urologists, we should also know about one of the important causes of obstructive uropathy. So if there is obstructive uropathy, we have to take care of the obstruction, either in the form of a diversion, percutaneous nephrostomy, or indwelling catheterization, and whatever diversion which is required to manage the obstructive uropathy. And once you have done with all this, then we have to think about which patients requires renal replacement therapy. So once the patient goes into G4 category, where there is a eGFR falls below 30, you need to counsel the patient for renal replacement therapy. And you have to think of getting the arteriovenous fistula and the access for dialysis. And we should all know the different indications for dialysis. Patients with pericarditis, patients with uremic encephalopathy, patients with fluid overload, patients who are resistant to all kind of medical management, whether this is hypertension, whether this is systemic signs and symptoms. So fluid dyselectrolytemia, or all these which are not manageable with medical therapy, where there we need dialysis. And then there is another treatment as well, conservative therapy. Patients who are very morbid, who have comorbidities, multiple comorbidities, they cannot are unstable on dialysis or hemodialysis, then we have to just take care of the symptoms and do the palliative care. So that is called conservative therapy. So we should all know all these things. You talked about peritoneal dialysis. So peritoneal dialysis are two types usually. One is when you do just put a catheter in and you do acute management with the peritoneal dialysis. And the other is the chronic management, which is done by CAPD, chronic ambulatory peritoneal dialysis. So all patients need not be on hemodialysis. Those who are unstable, they can go for peritoneal dialysis, which is CAPD. We have machines also available where the machines can do the peritoneal dialysis at home only. So this is otherwise a simple way, but you have to take care that there is no total aseptic precautions have to be taken so that there is no infection which enters into the peritoneal cavity, which is one of the dreaded complications of CAPD. So this is all about chronic kidney disease. If you have any question, just let me know. Otherwise, we'll go with the MCQs. Anybody has any question, any query, any comment? No? Right. So we go to the question answers. A hypertensive patient with CKD should take an ACE inhibitor drug to improve renal function, prevent progressive kidney disease, improve cardiac ejection fraction, enhance glycemic control, control blood lipids. Huh? Prevent progression of the disease? Yes, so I talked about that. So to prevent progression, we need to have two things in mind. One is blood pressure control, proteinuria control. And third is the fluid and diet management. So these are three things are very important to prevent progression. And then we have SGLT2 transporter, particularly for diabetic nephropathy for proteinuria, besides this ACE inhibitor and ARB. The most common cause for end-stage renal disease is focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, membranous glomerulonephritis, ADPKD, and diabetes. We know 30% of diabetic nephropathy leads to chronic kidney disease. And India is the capital of diabetes. So very important. The patient at lowest risk for progressive CKD is diabetic GFR 86, albuminuria more than 300, post-nephrectomy GFR 62, albuminuria less than 30, hypertensive GFR 75, albuminuria 80, IgA nephropathy GFR 42, albuminuria 70, autosomal ADPKD 28, albuminuria less than 30. So B. Okay. So GFR is more than 60, albumin is less than 30. So this becomes G2A1, right? So it comes under the green heat map, right? So it's a minimal risk. A hypertensive 38-year-old man has a serum creatinine of 2.4. The urine analysis has 10 to 20 RBCs, 3 plus protein, and RBC cast. Right? Ultrasound shows echogenic kidneys without hydronephrosis. The best way to achieve a diagnosis is renal angiography, biopsy, pyelography, MRI, spiral CT. So if you want to do the biopsy, if you want to know the cause, yes, biopsy is the way to ahead. All of the following promote fibrosis in the kidney except angiotensin 2, aldosterone, ANP, transforming growth factor B, high salt diet. A and B? C, A and P. A and P. You said A and P. Okay. So except A and P, all others cause fibrosis, is it? So all choices promote renal fibrosis except A and P, which may have the opposite effect. CKD patients treated with an ACE inhibitor may experience a decrease in their residual renal function in the setting of unilateral renal artery stenosis, concomitant treatment with an alpha blocker, acquired renal cystic disease, left ventricular hypertrophy, ADPKD with cyst more than 10 centimeters. Unilateral renal artery stenosis. Yes. Huh? What was the answer? ADPKD? Okay. With cysts more than 10 centimeter. So that is the cause for ACE inhibitor may experience a decrease in renal. Individuals with bilateral renal artery stenosis and autosomal dominant with cysts greater than size 10 cm may also experience a decrease in residual renal function while being given ACE inhibitor. So it's a bilateral renal artery stenosis, not a unilateral. Okay. The best renal replacement therapy for an otherwise healthy 37-year-old woman with chronic interstitial nephritis is preemptive transplantation. Best renal for an otherwise healthy with chronic interstitial. Stabilized with hemodialysis, stabilized with peritoneal dialysis, and home hemodialysis. Preemptive transplantation. Okay. A comparison of outcomes suggests that renal transplantation is the best overall treatment of ESRD, and preemptive is better than after dialysis, post dialysis, right? All of the following have a direct toxic effect on the kidney except iodinated contrast agent, myoglobin, gadolinium-based contrast agent, carboplatin, aminoglycoside, antibiotics. They have a gadolinium has toxic effect. It produces nephrogenic fibrosis. Yes, yes, nephrogenic systemic fibrosis. Yes. So, ये गलत है, ये कहाँ से? Where did you get it? It relates to the development of fibrosis, which can carry a high mortality in patients severely diseased. All of this denote direct toxicity. Okay. So it is only in patients with reduced GFR, is it? The strongest predictor of hospitalization in chronic dialysis patient is African American race, hematocrit less than 30, glomerulonephritis, poor nutrition status, age less than 30 years. Pardon? Poor nutrition status. Okay. The strongest predictors of the number of hospitalizations per year of patients at risk include low serum albumin, decreased activity level, diabetes mellitus is a primary cause of ESRD, peripheral vascular disease, white race, increasing age, congestive heart failure. Both nutritional status and inflammatory response are independent predictors of hospitalization of chronic hemodialysis patients. So again, the nutrition part is very important in chronic kidney disease. The bone issues, the bone complications, anemia, poor nutrition, all these are again very important. Right, thank you. So once again, I would request anybody, if you have anything to ask or any comments from anybody, otherwise we will wrap up the session. Okay, thank you. Thank you once again for joining this session. And I wish you a very happy day. Thank you.